Let me introduce the panel. These three you have met. You have not met Dr. Casey Schrum. Casey is president of the OSU Center for Health Sciences and dean of the College of Osteopathic Medicine. Thank you, Casey, for joining us. And I believe you've seen this man before, our Attorney General, Mike Hunter. Thank you very much for being here, Mike. Thank you, Casey. Since we've heard from these three, I'm going to start down on the end with you, General Hunter, and bring us up to date a little bit on the lawsuit against the opioid manufacturers and what your plans are for that.
I'm happy to. Thank you, Kelly, and good afternoon, everyone. Since we began this lawsuit, it has been my privilege to get to know some people around the state who have quickly become my heroes. So I understand that you heard and you've got some information about the Opioid Commission and the legislation that we were successful in moving through the Capitol. So there are some legislators here. So there's Representative Russ. Who else is here? Is Representative Young still here? Okay.
Representative Moore was here. Representative Moore was here earlier.
Okay. So the legislature gets a lot of criticism, particularly these days. You know, Will Rogers once said about Congress that sometimes an innocent man is sent to Congress. And it goes double for legislators. And it isn't every day as a legislator that you can vote on legislation that you know is going to save lives. And the legislation recommended by the Commission literally flew through the legislature, the House and the Senate. So I just want to give a real shout out to Representative Russ, to you and your colleagues for the great work that you did, the heroic work that you did in getting that legislation out of the Capitol, signed by the governor, and into effect, and it's saving lives every day. So I'm a Republican, and I believe in free markets and capitalism, and I could go on and on about that, and you don't want to hear that today. In my career as a lawyer, I have, most of the time, been on the side of lawsuits where I'm defending companies who are being sued. A lot of the times my work as a lawyer has been to keep companies from being sued. So this lawsuit, and I'm talking about the opioid litigation that Reggie Whitten and Mike Burridge are the lead counsel for on behalf of the state, it was a very difficult decision for me to make, having to sue companies that employ hundreds of thousands of people, that in many cases are pharmaceutical companies that are providing drugs that are important. But one of the things that was very clear to us in the Attorney General's office, and I've got a couple of very fine lawyers here that I'm proud of, Abby Dilsaver, who's the lead for our office on the lawsuit, and Lori Carter, who is actually the lead for us in getting the legislation passed. But we concluded that this was an example of what happens sometimes. Sometimes businesses do bad things. And I've had some experience working with large companies in the financial services arena. And when you get big, when you get diversified, when you have multiple departments and there's a decision-making tree that has to filter through hundreds of people, you have unfortunate results. So the genesis of this, it wasn't just somebody deciding to be evil. It wasn't just somebody deciding to distribute poison around the country for decades. It was a decision that the medical community made, that we needed to deal with pain, that pain needed to be a vital sign. So the challenge, the problem with all that is there's no objective way to measure pain. So there was an opportunity here for business, and the opportunity was let's come up with a magic pill that we can give prescribers that will address this vital sign, that will address pain, that will make a patient's pain go away. So the directive begins at the top of the food chain. I want a magic pill. I want our best and brightest, our smartest researchers to come up with a magic pill that we can begin benefiting from, that will fill the space that has been created by pain becoming a vital sign. So, the directive filters its way through the bowels, if you will, of the company, and research is done. And there's this tentative decision, or this tentative report that's made. We think that we can incorporate, we think that we can create a time release modification in opioids that will make them become non-addictive, but we're not sure. Well, how sure are you? Well, kind of sure. So instead of doing the research, because there was this rush to get this magic pill out in the marketplace, instead of doing the research, instead of employing the science that they had the responsibility to employ to provide the necessary basis for representing to prescribers that this was going to be a pill that would fill the space and not be addictive, instead, there was an approach of, let's convince people that it's not addictive. We're not sure, but again, we've got to get this pill out in the marketplace. So what happened? Hundreds of millions of dollars were spent on opinion leaders who were very well credentialed. There were entities set up that looked very legitimate, looked bona fide, that began generating studies to support the proposition that this time release modification that was being made on opioids was going to in fact make it non-addictive. Well, fast forward, it's now 2018. Hundreds of thousands of people have died or become addicted to opioids as a result of the decisions that were made over 20 years ago to provide this magic pill to prescribers. So where are we? Well, in Oklahoma, our research, our due diligence has brought us to a very, again, carefully reviewed, a thoughtful decision that these companies, these entities need to be held accountable for what they've done to the state. What are the damages to the state? Well, our damage model is being formulated. It's not dreamed up. There's already been thousands of man hours dedicated to working with entities around the state and determining exactly, in a very thoughtful, empirical basis, how much we as taxpayers have sacrificed, in many instances, without a thoughtful decision to deal with this crisis. We think the numbers aren't just in the millions of dollars, we think they're actually in the billions of dollars. And it may have a lot to do with why we have the budget challenges that we have in the state. So we've sued these companies. We are well into discovery down in Cleveland County in state court. Some of you may have heard that there's litigation all over the country that is in what's called multi-district litigation. All those lawsuits are in Cleveland, Ohio. They're being overseen by a federal judge there. There are literally hundreds of lawsuits from all over the country. Our judgment was that we wanted an Oklahoma jury to hear what these companies have done to the state. We want an Oklahoma jury to hear the facts, hear the evidence, and hold these companies accountable. We don't want to be in some, I'm being melodramatic here, some smoke-filled room in a faraway place, and be subject to a steering committee of, no offense, I know there are lawyers in the room, plaintiffs' lawyers from all over the country, and the decision being made, so how much are we able to shake down these companies, and what slice of the pie am I able to take home? That's not our approach to this. So Reggie and Mike are both victims of what's happened. And I just want to tell you, in the category of heroes, Reggie and Mike are heroes to me. They're not only great lawyers, they're not only great Oklahomans, they're people who are pouring their hearts and souls into this litigation. And criticism about this lawsuit, I think, has been disgraceful, but it's part of what happens in politics. And when we sat around and made the decision to go forward with this lawsuit, we knew that we were going to be attacked, and we knew that there were going to be challenges. But I will leave you with this quote, if I can, Kelly. Edmund Burke once observed that evil flourishes when good men do nothing. So I just want to tell you on behalf of our office, there are heroes at the head of this lawsuit, and they are dealing aggressively with the challenge that we've got, because effectively we're dealing with something that is very evil, and we're dealing with defendants who will stop at nothing to avoid liability in this lawsuit. So lastly, I'll just say, Kelly, this is not a sue and settle lawsuit. We are determined to hold these companies accountable for what they've done to the people of the state of Oklahoma. Thank you.
So that's what's going on kind of on the legal front. We asked Dr. Shrum to be with us today to tell us what she's doing and what they're doing in the OSU College of Medicine. To get on let's go a little further upstream about what they're doing to help prevent and educate soon-to-be doctors.
Well,
Casey?
thank you, Kelly. I think in order to start, just to kind of build on what the Attorney General just said, I was thinking back to, I think, probably 2011 when Reggie Whitten came to see me at my office shortly after I became the dean to share his story about Brandon with me and to ask me if he could speak to our medical students. And he left me a book, and as soon as he left, I read that book. I didn't get up from my desk, and I was really struck by his story and other stories that were in that book. And I think it's very important in dealing with the next generation of physicians in their training to personalize things. And we've heard a lot of a stigma, as Terry talks about frequently, around addiction. And I think putting a face and hearing stories, I think Gary for sharing your story, because it makes a difference. People who go into medicine want to help people. We don't want to cause any harm. And unfortunately, there have been some shifts and changes in the way that we were told to practice, and we did. But education is key. And experts like Dr. Kolodny speaking are important for physicians to hear, because this is how the pendulum swings back in the right direction. So it began, I said, absolutely, I want you to share with our medical students, because that's key, that's the starting point. And as we did that, and he began to share his story every year, and I began reading a little bit more and learning a little bit more about what's going on and what had happened through the drug companies, I recognized we needed to do a little bit more. So we began hiring addiction medicine specialists. We have 3 now on faculty, and they teach in our first year, in our second year of medical school. We require all of our students to do a rotation through addiction medicine clinics because it is a disease. And if we're going to get rid of the stigma, doctors have to start talking about it like a brain disease. And they need to understand the science of it, and that's the first place it starts. And so we began teaching that. I'm happy to say that as that's grown, we've started an addiction medicine fellowship. Monday, we'll be doing a ribbon cutting for an addiction medicine clinic. And from that, I think, one of the things that I would say is it is important to educate our providers and our future physicians, because that is prevention. So we've heard a lot about contain, prevent. Containing is getting out there and talking to physicians and changing the way they practice and getting them on board and hearing from, experts in the field who are going to tell them, look, this is what happened. Hearing from the Attorney General, hearing from Reggie Whitten, this story. Because as a practicing physician, when you're seeing those medical journals and people are telling you, you're a bad doctor if you're sending people away in pain. That's not what physicians want to do. And so now we have to tell them, look, that was wrong. And you need to see what happened, and you need to change your prescribing practices. And I believe that we can do that. But starting with this new generation of physicians is key. Preventing this type of activity has to come from educating them. We also just recently, I'm proud to say, have received a grant that will allow us to train all of our residents in Suboxone, so that we'll get them certified, which is important. And it's not something I think that the general medical community yet has totally embraced as the important thing to be in medical school and be in the curriculum. I mean, there was an article just recently, national article, about many medical schools don't teach it, and they don't. And sadly, media a lot of times only want to talk about, the bad outcomes, but they don't want to celebrate those things that aren't flashy. And sometimes, teaching those things in a medical school curriculum aren't, what gets everybody's attention, like having, a specialist that does surgery, on your right pinky finger. Those are things that people like to celebrate. But the truth is, we're more affected. Everyone in this room is affected by some form of addiction. Yet we're not celebrating that in medicine. And that's one of the things that we are doing at OSU is. I believe we have a moral obligation as an academic health center to address the needs of society, whether we feel like, that's something that our colleagues are going to hold us up in high esteem for. That doesn't matter. We're here to take care of the needs of society, and I hope at OSU we are training future physicians to do just that and becoming a standard for what should be expected. It should be expected for every medical school to do that.
So, Dr. Kolodny, I'm going to let you speak on behalf of your entire profession. Why is it that it takes a long time to turn doctors around? It seems like the pendulum is really slow to swing. What is that rooted in?
It's a really good question. I think that doctors certainly read the paper and they watch TV, and you can't read the paper or watch TV without knowing we have a problem with opioids. I think that, so why are they still overprescribing if we're all aware of this? That's hard to answer. I think that many doctors have in their mind that addiction is something that happens to a subset of our population, that there are addicts, and that the bad behavior that we do see addiction, that we know addiction can cause, people with addiction can behave badly in their pursuit of drugs. They make the mistake of thinking that it's not that addiction can drive people to behave badly, it's that bad people have addiction. And so if I'm a doctor and I've got a patient and I know that patient and I like them and I've known that family for a long time, the notion that I can prescribe a drug to that person and it would turn them into one of those people is completely foreign to them. And I remember when I was in training in a hospital and we had a patient who really did need opioids, and she was concerned and she said to the attending physician, but aren't these addictive? And his response, and it wasn't just to convince her to take them because she really did need them, I think he really meant this. What he said is, you have nothing to worry about. This is not going to turn you into the kind of person that steals radios from cars. It's not going to turn you into an addict. You might get dependent on the drug, which means we'll have to take you off slowly, but this won't give you addiction. You have nothing to worry about. That was his reassurance. And that's what many doctors think. And the other thing that many doctors think, and this was really the AMA's position for many years, which hasn't changed all that much, their idea was that the opioid crisis is really all about bad apples. It's about doctors who are drug dealers running pill mills, and we should stop them. And it's about the people out there pretending to be patients who are those addicts and abusers. But it has nothing to do with well-meaning doctors taking care of their legitimate patients. And so that when a state would say, you know, we're going to mandate that you get education, or we're going to mandate that you check the PDMP before you write a prescription, their response was, you know, when did you guys go to medical school that you're going to tell us what to do? And, you know, you're burdening us because of the bad apples. And what they're missing is that the bigger part of the problem all along has been the well-meaning doctors and dentists and nurse practitioners who are inadvertently getting people addicted, either their own patients or stocking medicine chests where family members are getting addicted, and creating customers for the pill mill doctors once people get hooked. So I think I think it really comes down to what we've been talking about and the need to better educate medical students about addiction. If we really understood that addiction can happen to any of us, I think doctors would be prescribing much more cautiously.
Okay, I have a question for the two of you. We did get a PMP pass, very hard-fought battle, and a lot of resistance from the docs. But we're still behind the states, and it needs to have more teeth in it. And then we're still prescribing too many meds. So, Gary, Terry's going to be at the Capitol fighting, stomping around in her boots like she always does. What advice can you give her, arm her, and what's working in other states? What are we missing? What's our puzzle piece that's missing?
First of all, I can't say exactly because I don't know Oklahoma as well as I probably should, but for sure, I looked at the PDMP law, and the PDMP law requires doctors to check it the first time a patient's prescribed an opioid or a benzodiazepine, and then every 6 months thereafter. It should be every 3 months thereafter, or if you want a model state like New York State, it's every time. Because then you don't have any of the confusion. Was it 3 months, 4 months? You have to go back to records. Just every time you prescribe, it takes literally 30 seconds. It can be delegated to a nurse who signs confidentiality of the information she's looking at, and she's trained. So a nurse can do it. It takes literally less than a minute. Hands it to a doctor, it takes a couple seconds, and then he knows. It should be done every time like New York State. So that's the PDMP law. I don't know in Oklahoma, does the information have to come from the pharmacies every 24 hours?
It's actually real time. We're the only real time.
Even
system in
better.
the
So
state.
that's even better. Great. Okay, good. What only one state has done, so I know Oklahoma has not, but only one state has, which is even better, is to have that information available on a confidential basis to the health insurers, because then they can use their algorithms as a much better blanket than a PDMP administrator to make sure that prescriptions, these opioids are being prescribed appropriately. No, only one state has done that. It's like so counter to me from the business world that everything has to go in stages. In the business world, you'd whiteboard this out. Here's the problem. Here's 10 solutions. Here's the big 3 that'll do most of it. Let's get these 3 done first, and then we'll worry about the other 7. In the healthcare world, in this world, what I'm saying is, well, phase 1, let's get a PDMP operational. Phase 2, let's make sure everybody registers with the PDMP. Phase 3, the law like in Oklahoma, where it's partially there. The things that we're doing are not the biggest movers. The biggest movers is they have it checked every single time, real-time data, which is great, and have the information available to health insurers who can use it, because it's going to, they have a financial incentive to use this information the right way to make sure the right people are getting it, and the people who don't need it are not getting the pills. And that's not being done anywhere except for one state. So that's on the PDMP side. On the prescribing side, generally, because PDMP is only 10% of the solution of prescribing. The bigger thing is what Dr. Kolodny was speaking about. It's changing the way that doctors think. There was a study done, which I suspect you know about, I think it was California, where they tested a control group and a study group where doctors, a certain set of doctors in the study, they were contacted every time one of their patients died of an overdose. And it personalized it for them. And immediately within the 6 months after, I think it was 6 months after, the prescribing of the doctors who were notified of a patient dying of an overdose went down by about 10% compared to the control group. So that just verifies exactly what Dr. Kolodny said. You don't think it can happen to my patients. And once they learned that it could happen to my patients, they started reducing their prescribing. The other thing is payment reform. If a patient comes in and they have an issue with pain, and an opioid is $50 to prescribe and it's easy and there's no prior authorization, or you want to send someone to physical therapy, which may cost a couple $1,000s, and there's prior authorization because it's more expensive, well, what are you going to do? And so we need to change payment reform. Again, nothing that complicated. This is nothing that complicated. The problem we're having here is Shatterproof, which is now 5 years old, just barely 5 years old. We're the largest doing everything out there. We're just not big enough yet. These solutions are not complicated. Payment reform, scorecard of providers. I mean, how could it possibly be that in 2018, less than 3 out of 10 treatment programs even offer one of the FDA-approved medications? Less than 2% offer all three. It's not that hard to change that. We mentioned earlier, prescribing buprenorphine. 8 hours worth of what was not mentioned is an 8-hour training, in addition to DEA approval and all the waivers and having DEA check up on you and all the things that go with it. Whereas 0 training to give someone OxyContin. These are not complicated things. And these changes have been made with smoking. They've been made with drunk driving. Look at the changes that came with equal marriage fairly quickly. When there's a will, there's a way. And we just need to bring people together, whiteboard it out, I can go on and on. The President's Commission report came out with 56 recommendations. They were not prioritized. There was not, any business in America would have had the 56 things, and then you'd have high, medium, low impact, high, medium, low cost, high, medium, low saves of lives. Piece of cake. They sent out 56 things that are not prioritized. Well, which ones do you do? Which ones are most important? No one's going to do 56 things.
The only thing I would add, just for context, that I think because there are some great things about our PDMP system. We are the first and only real-time in the nation. But our PDMP system in our state is housed in a law enforcement agency, which is a great partner. In almost every other state, it's housed in a public health agency. And the only difference that I'm saying there is we approach the way we use data differently. It was only in the last couple of years there was legislation passed that allowed that data to be shared with the Department of Mental Health and Substance Abuse Services. So we didn't even have access to the data, nor did the Department of Health. And so there's some thinking we need to continue to interject with our law enforcement partners who are doing a great job with the system to really have it used at a public health perspective. And I agree with everything else that Gary said about it is check every time. It is that simple. And it was a hard-fought 2-year battle just to get to every 6 months. And I actually think it would be different now, and we need to make it different now, but it needs to be every time.
And let me just add one thing to that. Most people think of prescription drug monitoring programs is the main use is you're eliminating users who are going to doctor shopping. You're going to one doctor, getting another doctor prescribing pills. That is one use There's another major use that most people aren't aware of. What most people don't realize is 30% of the overdoses related to opioids are a combination of an opioid and a benzodiazepine. The CDC guideline has 12 recommendations. Number 9 is check the database before every time you prescribe. Number 11, never prescribe an opioid and a benzodiazepine. The two together can be lethal. They both slow down your breathing exponentially when they're together. And so if a doctor doesn't check, he doesn't know. And the patients don't know. I'm sure there's people in this room, I didn't know it, that didn't know these two together can kill you. So how often does you have a son or daughter who has social anxiety and they're appropriately getting Xanax, appropriately? Once a quarter, they go to a psychiatrist and they get a dose the way they're supposed, and they take it the way they're supposed to. Then they go to, your son or daughter goes to college, gets hurt playing soccer, goes to the health clinic, and they prescribe Vicodin or Percocet while they're taking Xanax. The doctor doesn't check the PDMP, doesn't know. And then your son or daughter dies. This is not uncommon. It's so easily fixable. Sorry.
Okay, thank you. A lot of treatment centers still are 12-step based. How can we change, because I think the work of AA and Al-Anon and NA has been wonderful through the years and countless lives have been saved, but it doesn't work for everyone. What can we do to help facilitate change in understanding that medically assisted treatment is not, as I've heard people say before, you're just trading one drug for another? How do you handle that and get people to understand that you use insulin for diabetes? You can use Suboxone and things of the medically assisted treatment to keep people sober and keep them healthy. Who would like to speak to that? Terry, would you
Yeah,
like
I'm
to
going to
speak
talk
to that?
about some of that. So AA and NA are very helpful programs that are free. We should never be paying for AA or NA as a treatment program because it's free to any of us that want to engage in it. And for many people, it has been extremely helpful. But it is not an evidence-based medical treatment that you should be paying for. And so in Oklahoma, just so you all know, any drug or addiction facility that wants to exist in Oklahoma, for the most part, does have to be licensed by the Department of Mental Health and Substance Abuse Services. So we have some basic criteria that is part of our licensure. And one of those is actual treatment, not AA or NA, and it doesn't count toward your treatment hours. So that's, in Oklahoma, those programs aren't necessarily 12-step based, but around the nation and where a lot of folks in this room might send their kid or their loved one, they are. But our dilemma in Oklahoma, and this comes from being a really poor state, and it's really challenging. Guess how much we pay a day right now, and we just got a rate increase this year. Guess how much we pay for residential treatment in general in Oklahoma for any one of the providers I can actually find to go into this business that contracts with me? Yep, it was $82 a day. It's now $100. But residential treatment with the full evidence-based treatment protocol probably needs to be $300 to $500 a day. We pay $100. So guess how many people are getting the full complement of evidence-based services when they come through our system? Now, we've got some providers who are really amazing, Arcadia Trails being one of them, who, when they open their doors, are going to scholarship some of we're hopefully going to contract for our rate for the few people we can afford, and then they're going to scholarship on top of that so they can get the full complement of services, but that's not what most Oklahomans receive. And when Gary was talking earlier, he made a really important point that I want you to understand the nuance of in Oklahoma. If I was an insurance company that had all the healthcare expenses in my budget, this is easy. Because I increase the rate here, and I save a bunch of money on hospitalization and ER visits and all these things, and it works. But when you're only the Department of Mental Health and Substance Abuse Services, none of those savings occur in my budget. And so in order to raise the rate, we as a state are going to have to decide we're willing, initially, to invest some more dollars in treatment to get it to the full evidence-based complement, and then we will see savings occur in other places that we can put back in to make up for that spend. But there does have to be an initial investment. And the struggle we have in our state, not because of the folks who are here, because honestly, the legislators who came today are the ones who get this issue and care about it. It's the ones that aren't here that struggle to understand beyond often planning for just a one-year budget. And until we really make that shift, we're going to really struggle to get the full evidence-based services for so many Oklahomans who can only come through the system if they're able to touch my system, because so many Oklahomans cannot afford the treatment that is offered, that will be offered or that is offered out of state. It's just not available.
So I agree with everything Terry said. Some things to add to it. There's a little bit of an elephant in the room that Terry and I spoke about earlier. And one big benefit, and again, this is not political, it's not, Medicaid expansion would help a lot. So the reality here is, it is what it is, it's past. We can't change what back, we can only go forward. But this was created by a lack of oversight of our federal agencies. And Medicaid expansion will pay for 90% of the issues related to the people who need treatment today. And so that is one potential boost if the state wants to consider it. Back to your basic question, how do we advance medication-assisted treatment? It's state licensing. Now, I could say very simply, if you only license states, if the state only licensed treatment programs that offered medication-assisted treatment, that would then ensure that every person getting treatment would be offered one of the 3 medications that are FDA approved, and then that person could decide whether he wants to take the medication or try abstinence, up to the person, and either way is fine. And then you would say, well, that would hurt capacity because a lot of treatment programs can't provide that service on $100 a day. Well, a lot of this could be offered outpatient versus inpatient, which would
Exactly what we moved to.
which would lower the cost substantially and provide that. Suboxone, buprenorphine or Suboxone is approximately, it's $50 a month. So what's that, $15 a day? So excuse me, I'm sorry, it's $500 a month. So that's about $15 a day. So it's about $500 a month for buprenorphine. Methadone, I think, is a little less, and Vivitrol is a little bit higher. So there's, and again, it's not for every patient. They should be offered the 3 and let them decide if they want to take medication or try abstinence. It's not for every patient. And outpatient is a very viable alternative, which lowers the cost substantially. But state license, so I guess what I'm getting to, there's solutions. The solutions are state licensing. It would not hurt capacity if you moved more toward outpatient. And certainly Medicaid expansion would help a lot of people in this state. And then you have payment reform. You know, Massachusetts passed a law that if you want to prescribe one of the 3 FDA-approved medications, there's no prior authorization allowed in the state, Medicaid or commercial. That's an alternative for the state. We're going to be providing a roadmap to states, which we'll have later this fall, which we'll send to you, Kelly, and everyone here, which will include all these recommendations, much more detailed than I'll explain now. But there are solutions to this.
So I agree with everything that's been said, and there are definitely legislative approaches that would be incredibly helpful. To answer your question about people who might feel that buprenorphine is simply substituting one drug for another, to sort of carry forward your diabetes comparison a little further, type 2 diabetes is basically caused by being overweight. And if someone has type 2 diabetes and they can lose enough weight and eat right and exercise, you can get them off of their insulin. And if they do a really good job, you can even get them off of the oral medication for their diabetes. But that's very difficult for many people to do. If they can do it, it's terrific. It's better than being on insulin or medicine. If you could tackle any chronic disease through lifestyle change, that's better because medicines have side effects. But it is very hard for people to do. And we would never say to people with diabetes that, you've got 3 months of insulin, and then you better have your diet in check because we're taking it away. If we were to do something like that, what would happen is we would see a massive increase in blindness because the leading cause of blindness in the United States is diabetes. We'd see a massive increase in renal kidney failure from diabetes. It would be a public health catastrophe. And yet that is basically where we are with opioid addiction right now. We tell people with opioid addiction that either they're not going to have access to buprenorphine or they'll get it for some arbitrary time period, and then they have to be off of it. And of course we're seeing the public health consequences associated with that. So it is certainly better if people with opioid addiction could do all of the hard work necessary to come off of their buprenorphine. It's better than being on a medicine that has side effects and that you're going to feel sick if you run out of it. But many people can't do it. And for most people with opioid addiction, the abstinence-based approaches don't work. So we really do need that tool.
Dr. Shrum, Casey, you sounded like you wanted to say something.
Yeah, what I was going to say is, addressing the fact of being able to prescribe through, having these waivers available is important. When someone's ready for treatment or they want help, that's a moment in time that we have to, as physicians, when they're in our office, we have to be able to capitalize on that moment. Or when we do check the PMP and recognize there's a problem, we have to have those solutions available to us, and we have to have treatment options. So funding mental health and substance abuse is so important, and addressing these things through legislation that allow us to provide help to people when they need it.
I just want to, there's been one point that each of us have said that I just want to highlight in spades because I think it's so important. Whenever we say the word funding, which was just said, I just want to highlight, and I think we would all agree, if these solutions are implemented, it will save billions and billions of dollars. This is not a cost to our society. This is a net huge economic benefit, let alone the personal loss of folks like Reggie and I, which you can't put a dollar number on that. But this is not a cost. This is just spending some money up front to save money fairly quickly. Some of it is cost to different departments, which can easily be rectified. It would certainly be rectified in any business. And some of it is spend a little in the first 6 months and get it in the second year. We're not talking about 10 years of payback. We're talking about payback in less than 2 years. So I just want to just emphasize that point. Any time we say funding, this is not, it's savings.
I would like to hold this panel for another 45 minutes, but we're about to be kicked out of this room. I want to thank all of these people for joining us today. They're on the front lines. They're making a huge difference, and I'm deeply grateful. A couple of quick points. To earn CE credit for today's, please see Sarah Berry. She'll be out in the hall where the sign-in table was, and you can get that signed and taken care of. Secondly, we at the Oklahoman care about these issues. We care about our state, and we need your help. We frankly need your help. If you're not a subscriber, I wish you would be. Digital, print, however you like it, we got you covered. But if we want to continue fighting for our state, we need to be strong and we need to be in the black. So please support us. Thank you all so much for coming.